Hello, my name is Garry and this is my final project for patient-related outcomes. I started off today on my paper discussing my case study. My case study is a high school athlete who I worked with her senior year of high school, and she went on to play at a Division III soccer school. The fall of her senior year, she tore her ACL playing in an AAU soccer game. Came to me on a Monday, and after further evaluation decided that figured out she had an ACL tear as well as an MCL tear, and then upon review of the MRI also had a medial meniscus bucket handle tear. So my concern about looking at this is, because she had a total of 4 tears and 5 repairs, is there something that we missed as athletic trainers? Is there something that we could have done differently to evaluate her and determine her ability to return to play? And obviously with the class it is, could this have been done as easily as implementing some type of patient-related outcome measure? And that's kind of what the focus of mine on my project is on here, is why I decided to pick her. Could we have done something different? And that's obviously my biggest concern after 4 total tears and 5 repairs. So her first repair was done by the local physicians here in York, and she was fully functional. She had an ACL graft, or I'm sorry, she had a hamstring graft. We rehabbed her very well. She was as strong as could possibly be. Ended up going off to college, made it through all their preseason, made it the first 8 games. Halfway through the second half of her 8th game, she claims she was hit by another player. At the time. After the coach went back and reviewed, we realized that there was not a player probably within 10 yards of her when she felt the second pop. Was repaired again, this time because it was just a little over a year, actually under a year. They had decided to use a cadaver graft the second time. This time she had done it, her second tear happened her third tear, happened at 7 months of rehab. She was doing sideways shuffles, which was approved by her surgeon, the team physician at the school, and the athletic trainer. They felt she was ready for that. She tripped. Ended up not tearing that time, but stretching the ACL to a point where it was non-functional. Came back again, did another cadaver graft. This time 5 months out, slipped down the stairs of her apartment, tore again. Final time they decided, look, there's nothing more we can do. We've done everything we can. Your tunnel, it would take us 2 years to go back in, close your tunnels, get your graft ready. So they decided to send her to Freddie Fu in Pittsburgh, and he did what is called an over-under procedure. Her goal after every time was to come back to play, and she was close almost all those times until Fu fixed her, and Fu kind of shut that down. Okay, but one of the things that we're concerned about, and working with high school students is a little bit different than I know what most of you deal with in the collegiate setting and some in the professional setting. But one of the things that I'm with patients is, high school students, even the most athletic ones, are a little bit lazy, especially around the house. So when we look at what they're able to do non-athletic wise, they're not concerned about lost wages from not being able to work for the most part. They're not concerned about being able to put food on the table because mom and dad normally do that for them. They're not concerned about laundry because mom and dad normally do that for them. They're not concerned about being able to pay the mortgage, the cable bill, the phone bill, things like that. Those aren't things that are concerned to them. The main thing that they're concerned about is the social aspect of it. What am I losing by not being with the team? That's the hardest part of the social aspect. Being able to be in school with them now and see them on a daily basis does help a little bit, but there's nothing like that going out into battle per se in that athletic event. So, that is one of the things that we need to be concerned about. This young lady, she was very social, so she had very little issues with the disconnect from the team. It was nice out over the spring when we played soccer, so I was able to have her out. We did a lot of her rehab on the field that we could, right there with her teammates, so she felt a part of the team. We used the soccer ball, we kicked back and forth, so we were able to kind of integrate that into her plan a little bit. That's one aspect of this that working with high school kids is a little bit different. In the college setting, professional setting, yeah, they need to be worried about being able to walk up and down steps, maybe being able to do their laundry, get themselves food, things like that. So obviously those things are a little bit more important at the collegiate and professional setting than they would be necessarily with my high school student. If we move to part 2 of mine, I found an article done in the American Journal of Physical Therapy that I thought was very well written, and actually compared two PROs, patient-related outcome measures. One was referred to as the Lower Limb Functional Index, or LLFI, which is Appendix 1 in my paper, which we will discuss a little bit here in the future. The second one was the Lower Extremity Functional Index, or LEFI. I felt that actually in a high school athletic training setting, both could be valuable, using them both with a post-surgical patient. Whereas in just a general run-of-the-mill, normal lower extremity injury, the Lower Extremity Functional Index would be more appropriate because it's more conducive to athletics, and which you'll see as we move forward here. These were created by 4 physical therapists that had worked with a couple other agencies to excuse me, to fashion these for their specific needs. Now, one nice thing about this, it's not just, as it states in the name, it's not just for the knee. It works the whole lower extremity, hip to ankle, all the way down. So it's very conducive to what we're looking to do as far as getting some information from our clients or patients. Okay. In my setting, like I said, I could see the Lower Limb Functional Index being used more for post-surgery, because some of the questions on there are things we need to be concerned about. How are you sleeping at night? Is the pain too much? You can't sleep. Do you have to sleep on a recliner because you can't? You have to keep your leg elevated. Maybe those types of things are some things that we need to be concerned about, even at the high school level. Obviously, with this being created by physical therapists, even though they created both, they lean towards the Lower Limb Functional Index because it really was more related to the physical therapist aspect of of what they were looking to do. Okay. So, like I said, in part 3, I want to look a little bit about the percentages and errors. One of the nice things that was that we're always concerned about is what is the test-retest reliability, and that's kind of where I'm looking at with this. And if you find page 7 in my program in my paper, you'll see the third page here is table 3, kinematic properties of the Lower Limb Functional Index, LLIF, and the Lower Extremity Functional Index, LEFS is what they call it, scale. And it shows the test-retest reliability, the internal consistency, the error score, responsiveness, and missed responses. Okay? Now, these don't make much sense to you now because you haven't seen the instruments, but they will make a little bit more sense as we move down through the rest of part 4 into the 2 indexes, so that we can kind of discuss what they look like. Okay. If we look at part 4, what are some of the issues that I'm going to have? Obviously, as I've discussed, we had a very thorough discussion last week, is parental consent. And I kind of think over the weekend, as I continued to work on this and started to formulate my part 4, I think I kind of came up with a way of kind of getting around that. On average, I rehab 6 to 8 athletes a year that come back from a surgery. And through that time, I've become very close with the family, very close with the physician, very close with the athlete. And I think that I could use these PROs as a building block to be able to formulate data so that I could present it to my administration. Say, look, I'm being able to do this. I'm getting good feedback from the parents. They like this feedback. I'm getting excellent feedback from our team physicians. Because one thing that I would do is I would do all these initially, right, as soon as I get the athlete, but then I would also do them as prior to their doctor's visits. Okay, so we're looking at the Lower Limb Functional Index, seeing the athlete every day or almost every day. I have a little bit different perspective than the physician who sees them once every 2 weeks for 15 minutes. And I think that being able to provide them with the written, the student filled out PROs, would be able to help them kind of get a better picture. So it would help the overall general care. So I have to go back. We go back to my athlete whose third tear happened while she was doing shuffles. Even though all the clinical signs showed that she was prepared, was she really? Did she actually feel comfortable enough, in her daily life, what things she did on a daily basis, to say, yes, I am ready for shuffles. Okay, I can do lateral shuffles and I'll be fine. And maybe this was a freak thing. So the other thing that I prepared for, and working with kids 7 through 12, I deal with students that are as young as 11 years old and students that are as old as 19. So obviously that's an issue for me as well. So I need to be able to fashion all these things to be able to say, okay, look, I need to take what I have and be able to move it to multiple student ages. And obviously that's something that needs to be continued to be overcome as well. So I do apologize about the bell. I'm in school. So I would like to focus, well, maybe I would like to focus. Please excuse me. My apologies. Technology is great when it works right. Okay, so I'd like to focus number 1 on Appendix 1, which you can kind of see here is the lower functional, and you kind of get some idea about what it's really asking. Okay, so the instructions are, if an item describes you, mark the line. If not, leave it blank. If any item partly describes you, use the half mark. Okay, so you can see kind of a couple of things asking. I stay at home most of the time. I rest more often. My appetite is different. I sleep less. I'm weaker and or stiffer. I'm more irritable and I have a bad temper. Okay, yes, high school kids can all have those. So that's why, initially, when we're working through, especially sometimes the depressive part of an injury, this would be very conducive to a post-surgical thing. Okay, and then there are 25 total questions. Okay. And yes, it does. You have difficulty with stairs, difficulty bending, squatting. So it does incorporate some of those athletic things in there, and it also discusses a little bit about what the air is. And the air with this one is any change under 6.67%. Okay, so you can see all these are totaled up. Okay, based on, if you check it, it's a 1. Don't check it, it's a 0. Check it, put it half, it's a half. Multiply that by 4, it's out of 100. Okay, that percent, we have a percentage, and that's how we determine what the 6.67% of difference is, or it actually equates to 1.67 points. Anything less than that may be due to air. So the one that I would use the most would be this one. Okay, this is the lower extremity functional scale, and as you can see, it's a little bit more. It does offer a little bit more of what we're looking to do as far as athletes. Any of your usual work, housework or school activities. Okay, functional, sports. Maybe walking between rooms in the house. Okay, maybe walking between rooms in school. Okay, getting out of a car, walking a mile, standing for an hour, sitting for an hour. Okay, and this is where it kind of gets a little bit good. How it kind of helps us a little bit more. Running on even ground, running on uneven ground. Okay, making sharp turns with running and hopping. So as we're working through it, especially an ACL tear, we want to be, we don't want to be introducing this at 1 or 2 or 3 months. So we need to have some type of measure that we can use prior to that so that we can get to this. And I think that's where the lower limb functional index plays a part versus the lower extremity functional scale. So again, I look forward to your feedback. Again, I apologize about the quick little technical difficulties, but I look forward to all the dialogue throughout the week. And thank you.